like a block and it's like done.
So that should be
60, it's gonna be 66.
center reminder.
He didn't put me in his heart though.
I like your dad.
No, like when you're talking about,
Okay. That is a heart. Okay. It's beautiful. Don't anybody say otherwise. All right.
What did you say? That and heart?
This is
That
a
is a
heart.
heart.
This is a heart. This is a drawing of a heart.
Oh, that's a heart.
Right atrium, left atrium, right ventricle, left ventricle.
I thought you were calling lungs.
Okay, those are the lungs. I didn't draw them because they would look exactly the same. Fine, you know what? We'll just do this. There. That looks a little more like a heart, okay? Deal with it. That's what it looks like. Okay, congestive heart failure. All right, there's two main types. You have left-sided. And you have right-sided. I also, on your like notes, your clinical, your thingy, I gave you like a whole bunch of space on this thing, so you can write on that too. Just saying. Just saying. All right. So, your heart's when a heart's functioning, right? Here's what happens. Venous blood returns via the inferior vena cava and the superior vena cava. They drain into the right atrium. Do you need me to label the atrium right now? You're good on that? So, deoxygenated blood that your body's done with, right, comes up here and down here and fills your right atrium. Your right atrium hangs out and waits for a batch of blood, and then it pushes it through to your right ventricle, right? Your right ventricle then squeezes on contraction and pushes it out to your lungs. In your lungs, it perfuses your whole lungs. That lovely gas exchange happens, and it gets reoxygenated. When it comes back from the lungs, when it comes back from the lungs, it's beautiful, it's oxygenated, it comes back to the left atrium. Once it's filled up the left atrium for a minute, it comes through this next valve and goes into the left ventricle, which is the most important part of your heart. It's the one part you can't live without. Left ventricle, every single squeeze pushes it out through your aorta, which is actually up here, but I just didn't want to draw it up there because there's not very much room. And it sends it out via your arteries, right?
So that
Brain,
right here is
body.
the aorta?
This is an aorta.
Okay.
I'll label it. Superior vena cava, inferior vena cava. Okay. So that's how it's supposed to work. Now let's talk about, do you want a second to draw? Or are you guys
Yes,
okay?
please.
Draw quick. Sorry, you guys are stuck with my tab when you're ready. What?
That's left then.
Sorry.
Or leftish.
Okay. Alright. So, that's what happens normally. Let's talk about what happens not normally. Okay? Heart failure is actually failure of the heart, right? So the two sides of the heart that can fail are the right side and the left side of the heart. All right, let's talk about the right side first. So, what does your right side do? It collects the oxygenated blood and it sends it to the lungs. So when it's not doing that job, so when it's either weakly contracting because there's been some ischemia of the heart muscle and it can't contract anymore, so it's not having a good force push through to the lungs, or if there's pulmonary hypertension, which means that it's pushing but there's just a lot of resistance in the vein that's carrying blood to the atrium, the artery that's carrying blood to the lung, I'm sorry. Whenever there's pulmonary hypertension, this blood gets backed up. So think about this blood being backed up. Backed up in the right ventricle, backed up in the right atrium. So where does it go when it's backed up in those two places? It backs up to the superior and inferior vena cava, right? So when that backup happens, what do we see? So here we see JVD, regular vein distension. So that's our superior vena cava being too full of blood. Here we're going to see peripheral. We're going to see peripheral edema, mostly dependent, which means on gravity, and mostly in the lower extremities. Okay. Let's talk about some other places that are just kind of upstream of these spots. What did we just talk about that when it's not doing its job, you get portal hypertension? Close. Liver. All right, so when it's backed up here, it goes down into your feet, and it also hits your liver. So if you've got backup blood in your liver, you're going to have hepatomegaly, which is what? Enlarged liver, and splenomegaly. That's what it is. Because your spleen also is right there. Now the reason that these two organs, they don't really mind, initially at least, having more blood, because they can grow a little bigger to accommodate, and they're a little bit more patient than like your brain is, right? But what happens if you damage your liver due to extended backwards portal vein hypertension and like non-perfusion of oxygenated blood? What happens to your liver if it's get damaged? All that crap that we see, right? So remember, loss of clotting factors, loss of protein, loss of ability to manage glucose appropriately. So the biggest symptom that you're going to see here, especially because it's a fluid problem, you're going to see this IDs. Up to 10 liters in this case. Now, in right-sided heart failure, you can see high blood pressure. Why? Because basically it's just fluid overload, right? The fluid is leaking into the tissues, it's going everywhere it shouldn't, and your body just isn't doing a very good job regulating it because it just can't move very fast. So you're going to see elevated blood pressure, or you can actually, in right-sided failure, see hypotension. So both elevated and decreased blood pressure relate to right-sided heart failure. Why would you see hypotension? Remember what we talked about before, if you have not enough protein? You got it. Drop of oncotic pressure, leaving of the vascular space, so you get intravascularly depleted. I'm going to write that right here. You get intravascular depletion, right? So you actually look dehydrated, and you have all the symptoms of poor perfusion related to dehydration, even though you may be way overhydrated, right? So both of these signs, these are all signs, see how I wrote it, of right-sided heart failure, okay? That happens there. Left-sided heart failure. Now left-sided heart failure is the most common form of heart failure, right? Let's talk about what happens, right? So, in left-sided heart failure, usually left-sided heart failure is the one that starts first, actually. So this side, the venous return aspect of your cardiovascular system is functioning okay. So blood is making it from your body, through your heart, through your lungs, and into your ventricles. But in your ventricles, especially your left, this beautiful left ventricle here, it just stops being able to pump well. That can be due to a lot of things. Again, ischemia, it can be due to coronary artery disease, so you've just got really high systemic vascular resistance, drops your cardiac output, right? Remember heart rate, systemic vascular resistance. Remember that one? I'll say that again. Heart rate. Right? No, this is stroke volume. This is something else that actually that applies. There we go. Just throw as many initials as I can at you so that you're really confused. So, heart rate times stroke volume is equal to cardiac output, right? So if your stroke volume is dropped because of increased systemic vascular resistance, or because of decreased strength in your left ventricle, you're going to have a drop in cardiac output, right? So what happens is that drop in cardiac output means this ventricle is going, and it can't pump the way that it needs to. So the aorta you get depleted in your body. So what's a frequent sign and symptom? You got it. Drop in blood pressure. Okay. That drop in blood pressure leads to what all over your whole body? Decreased perfusion. Somebody said it actually.
Greater cap rate.
So, decreased perfusion means good. Slow cap refill.
Are you gonna get that muscle pain in your leg? Not having.
The intermittent, what is it?
Yeah.
Claudication?
Yeah.
Not necessarily.
No.
That's more venous return actually.
Okay, I knew it was one of those. I saw it was not it.
Cool extremities. Right? Weak pulses. What else comes with the lack of perfusion? Weak, fatigued, pale. Okay. Okay, so that's one part of what happens here. But there's another problem. So that's what happens when there's not enough blood going out. But there's still plenty of blood coming in. So where does it build up?
Lungs.
In your lungs. Left lung, baby. L and L. That is the one thing you should remember about heart failure. Left lung. Left lung, left lung, left lung. Alright? So all this great venous blood is making it to your heart. And your right side is like, yeah, I know I'm doing pump into the lungs, pump into the lungs, pump into the lungs. Lungs are like, okay, great, let's get rid of this blood. And your left ventricle is not able to receive it. So it builds up in your lungs. And your lungs, as we know, can act as a reservoir for fluid. Sometimes this is good because it allows you to accommodate. You can actually have a fair amount of fluid inside your lungs and still be breathing okay, right? It's sort of a buffer. But when you have too much fluid in your lungs, you start getting symptomatic. So you get pleural effusions. / pulmonary edema. The difference between these two things, one is inside the alveoli and one is in the space between the alveoli. Okay, you get both. All right, so what does that mean? What do you see with somebody who's got pleural effusions or pulmonary edema? Specifically, what do you hear? You can also hear rhonchi. Is it rhonchi? Wheezes. Because your air passages in your lung are getting clogged up. You hear crackles and wheezes. What do you think happens to your oxygen saturation? Got it. What happens if you fill up with fluid? Who had the patient who had the cancer That was like the lung cancer that was
Oh,
Rhea.
that
It was
was
Rhea.
Rhea.
So she's not here. All right. You get pink, brachy sputum. That's a classic sign of your lungs filling up with fluid, right? And you, of course, and then there's one last thing that's very significant about heart failure patients, especially when they're left-sided. So let's think about it. Your lungs, so imagine my lungs right here, right, are filling up with fluid. That's fine if I'm standing upright, because I got this whole lung to breathe, right? That's like more than half of the surface space, because it's all like right here, right? What happens if I lie flat? No, you're not after. You already have fluid in your lungs. You cover up a lot of your surface area to actually breathe with. It feels like you're drowning. So we call that
Orthopnea.
Mm-hmm.
Is that why you do like 1, 2, and 3 pillow orthopnea?
So that's how we grade orthopnea. Yep. How many pillows it takes for somebody to be comfortable in a lying position or kind of a seated position. So it's pillow rated. I think that's so fun. Excuse me. Okay. The last thing that frequently happens with left-sided heart failure is you hear some adventitious heart sounds. So you'll hear an S3 or S4 sound. Right? That's because the left ventricle is contracting, those valves are contracting, but the blood's turbulent. It's not going out the way that it should. It's like getting spun around and backed up, and that's what makes the clicks. All right. The S3 is the most common and first sign of heart failure. Okay. Left-sided heart failure. All right. So, left lung, right body. All right. That's what happens to the fluids that you've got. Okay. Now you see why you see everything. Now, what can cause left-sided heart failure? This is the most common one. The most hard hitters are what we see with cardiac patients all the time. Give me some.
Ventricular.
Huh?
Can I call that?
What? I didn't hear what you said.
Left ventricular
So left ventricular hypertrophy is actually a compensation that your body's trying to do to make up for the fact
Okay.
that it's not functioning. So actually, that's kind of a symptom. Over here. Okay. Hypertension. Courtney, what's the other one that goes hand in hand with hypertension? You just said it earlier for the other thing.
Coronary.
There we go.
Oh,
Sorry.
I have a question.
Uh-huh.
So my patient doesn't technically have the diagnosis of hypertension, yet chills at 170, 180, but she has CAD, PAD, heart failure with that HF, PEF. I wrote it down. It's like
Pleural effusion or
no,
pulmonary
it's
something?
like
Ejection fraction?
yeah.
Okay.
So she doesn't have
She's not diagnosed with hypertension?
but she's
So
like,
she probably is hypertensive and she probably does have hypertension. We don't like to diagnose chronic diseases in the hospital because you don't know if the symptoms that you're seeing are due to some acute exacerbation
right.
or they're chronic.
Right.
So she probably has hypertension. Maybe she doesn't have a primary care doctor that's following her really closely, or she hasn't had like a blood pressure taken when she's not sick in the past 2 years. Doesn't mean she doesn't have it.
Right.
Okay, so hypertension, CAD, and there's one other cardiac thing that causes left-sided heart failure, and that's valve disorders. As I'm sure it makes sense, right?
Mm-hmm.
If the aortic valve gets super stiff, the heart has to work harder and harder to push blood through it, right? So specifically, the mitral or aortic valves. Of course, the valves that hang out on the left side. Okay, those are the causes of left-sided heart failure. The causes of right-sided heart failure. Mm-hmm. Good one.
COPD too, right?
Yeah, because of pulmonary hypertension.
Right, so it causes that.
So does that make sense to everybody why pulmonary hypertension would cause right-sided heart failure? because your right ventricle, its job is to push things through your pulmonary artery to your lungs. If your lungs are not receiving blood very well because they're stiff and non-elastic, probably due to COPD or whatever else, you're going to have that pulmonary hypertension. That means that you have high pressure in your pulmonary artery, which then makes it harder and harder for your right ventricle to push blood through, which then makes it back up, right? That makes sense? So pulmonary hypertension is going to contribute to right-sided heart failure. Also, left-sided heart failure, because it'll just back up all the way, right? And the last most common cause is MI. Okay, that ischemia, if it lands anywhere that, kind of like anterior, any of the muscle that's on the right side of the heart or functioning in the right side of the heart, if it dies and it's not contracting very well, then you're going to have that backup because the lungs are pretty hard to push blood through. Okay.
Low battery.
Can we talk about ejection fraction?
Mm-hmm. So, great question. In left-sided failure, there's actually two kinds of left-sided heart failure, systolic and diastolic.
Right.
Green or orange?
Right.
So let's reason this out. What do you know about systolic? So remember, systolic is when the left ventricle is contracted. Diastolic is when the left ventricle is relaxed. So systolic heart failure is probably heart failure that occurs when the left ventricle is not contracting. Right? So that's actually, it's sort of a pump problem, right? So the pump is not pushing the way that it needs to. Now in systolic heart failure, you have not contracting, or you have like a decrease in the force of the contraction. The big way that you can tell the difference is you have an ejection fraction of less than 40%. Because, of course, it cannot eject. It's not injecting, it's not pushing out stuff, right? Now remember, do we have 100% ejection fraction? No. Anybody that's healthy, you, me, we usually have about 80%. 80% is the 100%. And I hate that that's like that, but it's because it's normal for blood to pool in every single heart. It's just not pooling for long or for very much of it unless you have issues. So remember, that's what I mean by ejection fraction. Less than 40% ejection fraction, you've got some systolic left-sided failure, right? Diastolic, it's not a problem with contraction. What's it a problem of?
Relaxing.
Not relaxing. We need to chill out, man. Okay? So when it's not relaxing, when the ventricle's and it can't, what can it not do during the heart cycle? Fill. So that means no filling or less filling. So the problem is not that the ventricle cannot squeeze enough. It's that the ventricle cannot fill enough to push enough out. Okay? But that's actually less of a problem than systolic heart failure, because even with low filling, it can still, if this left ventricle is functioning and the muscle itself is okay, it can still keep up cardiac output for the most part. So you're going to see an ejection fraction of greater than 40%, usually, with diastolic failure. But I'll give you a hint. What happens with diastolic failure after a little bit when the left ventricle has been pushing hard, like to try and get stuff through, what happens? It stops being able to contract as well. That muscle gets tired. Then you drop your EF, and you're going to see all these symptoms. Okay? All right. So what do we do about hypertension? There's a few things that we can do medically to treat somebody with hypertension. Should I erase this so that I can write those things down, or should I just tell you those things? You want me to write it down? I can write it over here. Rachel, if I write up to here, are we good still?
Mhm.
Okay.
You're good all. I moved it, so you're good
Oh.
all the way over.
Fantastic. All right, so what do we do about hypertension? Okay. What's the problem when we come, or about hypertension, about heart failure? What's the problem with heart failure? What is causing all of these symptoms? Fluid in the wrong places. Yes, exactly. Fluid in the wrong places. So what's the easiest thing to do?
Take it off.
Get rid of that fluid. How do we do that?
Diuretic.
Diuretics. You got it. That is the number one treatment. People can have heart failure and live comfortably in heart failure for decades, and they like take 40 milligrams of Lasix every day. They just pee a bunch. It's just what they do. And it's totally sustained, right? Especially if it's well managed, okay? So let's say that diuretics aren't cutting it anymore, and the patient is just starting to get fluid overloaded, and they're still having hypertension, which is causing further damage to the heart, which is exacerbating their heart failure. What else can we do? What can we do to somebody who needs to
Vasodilation.
vasodilation? Thank you. Right? So time out for a second. Now we'll finish this discussion, then I'm going to go to something a little more basic. Okay. Vasodilation. How do we cause somebody to vasodilate? What do we give them? I'll give you a hint. We use it. EMTs use it in the field all the time. It's one of the few drugs that we can give people. Epi?
No.
Close, but no. Nitrates. Nitroglycerin.
Oh.
Right? Because what does that do? It decreases your systemic vascular resistance, which makes it easier for the stroke volume to occur, which will improve your cardiac output, right? Nitrates. All right. Any other guesses? Increase the contractility. Fantastic. Any guesses on what drugs do that? Digoxin, which is an inotropic. I don't think I spelled that right. Is there an extra O in here
I
somewhere?
don't think so. I think maybe there's
I think it's INOTROPE. But don't trust me with spelling.
Maybe there's an O or not in there. You guys worry about that. Dig. Dig, baby. All right. Digoxin is one of the drugs you need to memorize everything about. Man, do they love to ask about digoxin on NCLEX questions. Okay, you need to know the normal range for digoxin levels, which is, stand by.
I used to know this.
Oh, not in here.
I have
think
it.
it's like
You want it?
0.5 to 1.5 or something
I
like
can
that.
tell you.
Yeah, sure, let's see that.
While she's looking that up.
While she's looking at, so remember, diuretics to reduce fluid. Nitrates, vasodilate, reduce systemic vascular resistance. That's a V.
But won't dilating cause more peripheral edema? Because of the...
It depends on the protein. Vasodilating by themselves just relaxes the veins, doesn't open them up for
Okay. For that.
It doesn't make them more leaky. It just makes
Okay.
them relax and bigger. Inotropes increases contractility.
Dig tox is 0.8 to 2.0. So max daily is 0.125 mgs to 0.25 mgs.
There you go. Okay. 0.8 to 2.0, remember that. All right. There's one more kind of medication that we like to give people that increases their cardiac output. Wait. Oh, decreases their blood pressure and via their systemic vascular resistance. It's another vasodilator, sort of. Not really dilator, but it decreases their blood pressure. We give it to people all the time for hypertension. Beta blockers. Like midtope. Okay. This is these 4 drug categories are the classic meds that we're going to put somebody with hypertension or heart failure on. Alright, these are going to manage the majority of their symptoms. Beta blockers decrease hypertension, decrease systemic vascular resistance. Right? Again, with beta blockers, hypertension, you're also risking decreasing their heart rate, which will reduce their cardiac output. But it's kind of your balancing problems here at this point, right? Besides drugs, what else can we do? What happens if this situation is going on? Yep. Okay. Sure.
Well,
So what does diet have to do with it?
Well,
Diet and exercise. There's something specific.
if you decrease, sorry, go. What, did
You got it,
say?
Jen?
Sodium.
Sodium. Yep. You got it. So along with diet and exercise, which are super important, of course, if you have sodium levels that are high, you're retaining water, which is going to go against this. So diet,
Dash diet.
What about
low sodium.
what about cholesterol?
Yep, that would decrease the CAD, which would make the blood less viscous. So what did you guys say? Isn't it DASH diet?
Mm-hmm.
That's low cholesterol too, right?
I have a question.
Mm-hmm.
In terms of like cholesterol and stuff, I was trying to find my patients, but it's not in any of the results. Is that like a different thing?
It's because they don't necessarily test
Or
it.
they just don't test it?
It's not something we can do much about in the hospital. We can maybe put them on some like statins, but we're not really worried about. That's a chronic problem, not an acute problem. In the hospital, mostly we deal with acute problems, and then we say, "Good luck with all your chronic problems that lead you to us. You're on your own with that." And then they
Okay,
come
so
back.
they don't really care. I mean,
They-
with all the love in the world, they don't care.
Right, and it's something that we can't affect right now, so
Yeah.
we're not really worried about it. If we're not going to treat it, we don't need to test for it.
Okay.
All right, so diet is important, and then supportive measures. Right, this really falls under nursing. These last two things. So what happens if this is a problem? What can we do to keep them comfortable and make sure that they're perfusing appropriately? Sit them up, positioning. All about that. Suctioning, although a lot of times when they've got pleural effusion, they can't cough it up. It's not at the level of actually like your coughing reflexes. It's too low. But we can do something for them. We can give them something. Oxygen. Sinus spirometry is great. Definitely useful in this place. Okay? So these meds are important. But honestly, these things are the things that make people feel actually better, like they're not drowning. Okay? Questions? More questions? You like this? Make sense? Mm-hmm.
Is there any reason that for a patient who didn't have a history of anything wrong with their parathyroid, in terms of like CAD, PAD, that she would be on Cinalcalcet, which is the parathyroid hormone? Does that make any sense to you?
So it's a parathyroid hormone. What does parathyroid do? What is the job of the parathyroid?
It increases calcium and phosphate levels.
Mm.
Oh, then it goes back to the renal.
Renal stuff and anemia.
Oh, okay. That makes sense.
Questions? Good. Since you've understood that so well, go ahead and turn that off and you guys are going to do the quiz. Not quiz, actually. Not a quiz at all. I'm going to hand you NCLEX questions. You're going to have